If you just found out you need a cardiac ablation for AFib and you are scared, I want you to hear something first. Most of what terrifies patients about this procedure is based on what they imagine is happening, not what is actually happening. And here is something your doctor may not have had time to explain. A major study published in the New England Journal of Medicine in 2023 tested a brand new ablation technology. The results showed 0 esophageal injuries, 0 nerve injuries. That is a complete reversal from where we were just 10 years ago. So today, I am going to walk you through exactly what happens during an AFib ablation, from the moment you walk into the hospital to the moment you walk out, step by step, in plain English. No jargon, no fear-mongering, just the truth. And stay with me through the end, because I'm going to tell you the one thing most patients get wrong after the procedure. It is the mistake most likely to send you back to the hospital. Let us start with why this procedure exists in the first place. AFib, which stands for atrial fibrillation, is the most common heart rhythm disorder in the world. And here is what most people do not fully understand. AFib does not usually kill you directly. What it does is create the perfect conditions for a stroke. When your heart quivers instead of pumping properly, blood can pool inside the heart. When blood pools, clots can form. And those clots can travel directly to your brain. That is why your doctor is taking this seriously. That is why ablation exists. Now here is the good news. The 2023 guidelines from the American College of Cardiology and the American Heart Association gave catheter ablation a Class 1 recommendation. That is the highest level of support a treatment can receive. It means this is not experimental. It is not a last resort. For the right patient, it is the recommended treatment. And a major clinical trial published in the Journal of the American Medical Association confirmed what patients already feel. Ablation dramatically improves quality of life compared to medication alone. Fewer symptoms, more energy, more freedom. But here's the question nobody answers clearly. What actually happens during those 1 to 2 hours you are on that table? Let me show you. Think of your heart's electrical system like the wiring in your home. In a normal heart, electrical signals travel in a clean, organized path. Your heart beats in a steady rhythm. Everything works the way it should. In AFib, there are faulty wires. Rogue electrical signals fire from inside the pulmonary veins. Those are the 4 blood vessels that carry oxygen-rich blood from your lungs into your heart. These rogue signals overwhelm your heart's natural pacemaker and throw the entire rhythm into chaos. Ablation is essentially an electrician coming in and cutting off those faulty wires permanently. The doctor uses a thin, flexible tube called a catheter. It is smaller than a pencil. That catheter is guided to the exact source of the problem. Then it delivers controlled energy to create tiny, precise scars around the pulmonary veins. Those scars act as a wall. The bad signals cannot get through. Your heart goes back to beating the way it should. This process is called pulmonary vein isolation. It is the foundation of every AFib ablation performed today. It is confirmed in the 2017 Heart Rhythm Society Expert Consensus and reaffirmed in the 2023 ACC and AHA guidelines. Now let us walk through the actual experience. Starting before procedure day, in the weeks leading up to your ablation, you will have blood tests, an EKG, and likely an echocardiogram. That is an ultrasound of your heart. Your team may also do a CT scan or MRI to build a precise 3-dimensional map of your heart's anatomy. Think of it as GPS for your electrophysiologist. Now here is something critical about your blood thinners. This is where I see a lot of confusion. If you are on apixaban, rivaroxaban, dabigatran, or warfarin, the 2023 ACC and AHA guidelines gives a Class 1 recommendation that you continue your blood thinner right up to and including the day of the procedure. This is called uninterrupted anticoagulation. Research confirms it is the safest approach. Do not stop your blood thinner unless your doctor explicitly tells you to. The night before your procedure, do not eat or drink anything after midnight. You may take approved medications with a small sip of water. Arrive at the hospital 2 to 3 hours before your scheduled start time. You will check in, change into a hospital gown, and have an IV placed in your arm for fluids and medications. Once you are checked in, nurses will take your vital signs and repeat some blood work. Then comes a step that surprises most patients. Before the ablation begins, many patients undergo a transesophageal echocardiogram. You may hear it called a TEE. A small ultrasound probe is gently passed into your esophagus, which is your food pipe, to look inside your heart for blood clots. We are specifically checking a small pouch called the left atrial appendage. This is a safety step. We need to confirm no clots are present before we begin. You will also meet with the anesthesiologist. Most AFib ablations are performed under general anesthesia. You will be completely asleep. Some centers use deep sedation instead. Either way, you will not feel anything during the procedure. Once you are asleep, here is what happens. The doctor makes 2 to 3 small punctures in your groin area, not your chest, not your back, your groin. Thin catheters are inserted through the femoral veins, which are large blood vessels in your upper leg that connect directly to your heart. There is no open heart surgery, no incision in your chest, no ribs being moved or opened. The catheters are guided upward through your blood vessels to your heart using a sophisticated 3-dimensional mapping system. Your heart is being mapped electrically in real time, like a GPS tracking every single electrical signal as it moves through your heart muscle. To reach the left atrium, which is the chamber where the pulmonary veins are located, the doctor performs what is called a transeptal puncture. A tiny hole is made in the wall between the right and left chambers of your heart. I know that sounds alarming, but this is completely routine. That small hole heals on its own within weeks. It does not require any repair. Now comes the ablation itself. The doctor delivers controlled energy through the tip of the catheter to create small scars around the pulmonary veins. Those scars electrically isolate the veins from the rest of the heart. The rogue signals are blocked. The abnormal rhythm loses its trigger. There are 3 main types of energy used today. The first is radiofrequency ablation. This uses controlled heat to create the scars. The second is cryotherapy. This uses controlled freezing instead of heat. The third is pulsed field ablation. This is the newest technology. It uses short, precise electrical pulses that specifically target heart muscle cells while sparing surrounding tissue. That last one is worth paying attention to. The ADVENT trial, published in the New England Journal of Medicine in 2023, showed that pulsed field ablation achieved the same effectiveness as traditional thermal ablation, but with 0 esophageal injuries and 0 phrenic nerve injuries. The phrenic nerve controls your diaphragm and your breathing. Protecting it matters enormously. Procedure times were also significantly shorter with this technology. Pulsed field ablation is now being adopted rapidly at major cardiac centers across the country. Throughout the entire procedure, a blood thinner called heparin is given continuously through your IV. This prevents clots from forming on the catheters while they are inside your heart. The whole procedure typically takes 1 to 2 hours. You wake up in the recovery area. The catheters have already been removed from your groin. Pressure is applied to the puncture sites to stop any bleeding. This is done either by hand or with a small closure device. You will need to lie flat for 2 to 6 hours while the puncture sites seal properly. Nurses will monitor your heart rhythm, blood pressure, and groin sites closely during this time. Some mild chest discomfort is normal and expected. Here is some genuinely good news. Many patients go home the same day. A 2023 study published in JACC Clinical Electrophysiology demonstrated that same-day discharge is safe and feasible for uncomplicated procedures. Some patients stay overnight, particularly if the procedure finished late in the day or if additional monitoring is needed. Now here's the most important thing I will tell you in this entire video. When you wake up after the procedure, your blood thinner must be restarted, usually as soon as you can swallow, and you must continue taking it for at least 3 months after the ablation, regardless of how good you feel. The 2023 ACC and AHA guidelines and the 2017 Heart Rhythm Society expert consensus are absolutely clear on this point. Ablation does not eliminate your stroke risk immediately. The scar tissue is still forming. The heart is still healing. Your blood thinner is protecting you during that window. This is non-negotiable. Do not stop it on your own. Now, I want to talk about something that causes a tremendous amount of unnecessary panic in patients after ablation. In the first 3 months after your procedure, you may feel your heart skipping beats. You may feel palpitations. You may even have brief episodes of AFib. Please do not panic. This is called the blanking period. It is a healing phase. The scar tissue is still forming around the pulmonary veins. The heart is recovering and adjusting. Early arrhythmias during this window do not mean the procedure failed. They are expected. They often resolve completely as the heart heals. Think of it like a surgical incision on your skin. In the first few weeks, it looks red and feels tender. That does not mean the surgery failed. It means your body is healing. Your follow-up schedule will typically look like this. 1 to 2 weeks after the procedure, your care team will call to check on your recovery. At 3 to 4 months, you will have an office visit with your electrophysiologist. At 6 months and 12 months, you will wear a Holter monitor, which is a portable heart rhythm recorder, to assess how your rhythm is doing. At 3 months, many centers also order a CT scan to check that the pulmonary veins have not narrowed during healing. Let us talk about what you can realistically expect. Based on current evidence, including a comprehensive review published in Nature Reviews Cardiology, approximately 70 to 80% of patients with paroxysmal AFib, which means AFib that comes and goes, are free from AFib at 1 year after a single ablation procedure. For persistent AFib, which means AFib that stays continuously, the success rate is approximately 50 to 70% after one procedure. Some patients need a second procedure to achieve the best result. That is not failure. That is biology. And second procedures tend to have even higher success rates. Here's something else worth knowing. Even if you feel great after ablation, even if your rhythm feels completely normal, ablation does not automatically mean you can stop your blood thinner. That decision is based on your individual stroke risk score, not on your heart rhythm. Your electrophysiologist will guide you through that conversation at your 3-month visit. Major complications from AFib ablation at experienced centers have dropped to under 1%. This procedure has become one of the safest and most refined interventions in all of cardiology. If you have been sitting with fear about this procedure, I understand completely. But I want you to leave this video feeling informed and empowered, not more anxious. AFib ablation in 2024 is backed by decades of research, refined by technology like pulsed field ablation, and supported by the highest level of clinical guidelines available. You are not alone in this, and you have real options. Here is your action plan before your procedure. 1. Do not stop your blood thinner without explicit instruction from your doctor. 2. Ask your electrophysiologist which ablation technology they use and why. 3. Understand the blanking period now so you do not panic if you feel palpitations in the first 3 months. 4. Plan for 1 to 2 weeks of light activity after you go home. No heavy lifting, no strenuous exercise. Short walks are encouraged. 5. Keep every single follow-up appointment. Rhythm monitoring after ablation is how we catch problems early and protect you long-term. Make sure to go to fightafib.com to download your free AFib patient guide and sign up for our newsletter. If this video helped you understand what is ahead, please share it with someone you love who has AFib. They deserve this information too. And drop a comment below. Tell me how long you have had AFib and whether you are considering ablation. I read every single comment. Next week, I will be covering the top warning signs after ablation that you should never ignore, including one that sends patients to the emergency room when it could have been caught much earlier. I am Dr. Yasser Rodriguez. Stay informed, stay empowered, and I will see you in the next video.